this system here, which will be the backbone, if you will, of our remote support program here at HARC. So our guest speaker today is Dr. Mike Strauss. He is out of Kansas City, and he's joined with two of his colleagues, Megan and Beth, who are going to give us a complete understanding of their program, what the complete benefits are as it relates to all of you and all of the individuals that we serve. So I will pass it on to Mike and let him introduce and get the program started.
Can everybody see it?
We see it.
All right. Well, let's go.
Go.
All right. I'm Mike Strauss. I am the CEO of Good Life Innovations, and as 40 years actually as of last week, and of iLink Technologies, which we're going to talk about today. But I do want to also talk to you about a very special relationship other than the ones we have with you guys, and that is we have a 50-year partnership, a little right at 50 years actually, maybe a little over, with the University of Kansas Department of Applied Behavioral Science, and they provide us with anywhere from 12 to 15 postgraduate and postgraduate faculty who have worked with us literally for 5 decades on developing best practice service models and more recently technology. When I talk about more recently, though, I do believe we're the oldest remote support provider for IDD in the nation. We started our first projects for remote support in the year 2000, which is almost incredible to believe that we have been doing it for that long. We're probably in the 6th generation of this support and of its technological sort of R&D development. So we got a lot to share with you. And as fast as I could tell you that, technology changes again, and we continuously work on all of this. So we're very proud of our connection with the University of Kansas. It's meant a lot to us. A lot of our work has been published and is evidence-based. So you kind of have that as a background. I'm a behavioral analyst by training. I'm also with that department as well as with Good Life as a faculty. We have I want to say we have an important mission. And not only do we help agencies across the country, I think since COVID, we've actually worked and done work in about 20 states. So we have a fairly large reach. But I wanted to tell you the most important thing is that we're also a service provider. We provide about $40 million of annualized services in Kansas and soon Arkansas. We're a not-for-profit. But one of the reasons that we do that is that, everything that we help people with, we actually first do and demonstrate within our own program. And I will tell you, about 5 years ago, we changed our mission formally. It used to be to make a meaningful difference in the everyday lives of persons who need help to live a good life. And primarily that was people with IDD. But we added more recently, about 5 years ago, and those who support them, because we believe and we've always believed as an agency that you can't support people who need help to live a independent, good life without helping the people who make that possible, which is our direct support workforce, which has been incredibly fragile for 50 years. And we'll talk about the research that we have done in that area as well. But this is an important vision, and our goal is sort of to redefine what's possible. And we do that largely with all of our staffing models that we develop that are really developed around what technology makes possible. So as I said before, everything that we do, we create, use, measure, assess, refine, and replicate before we disseminate at Good Life. And we learn a lot from the people we work with. And so that feeds back into our sort of continual R&D on how we can improve things. If you'd like, Megan can always share this with you, but we have a lot of information on our website. This is a QR code for that. We'll send the PDF versions to you if you want that. But that'll connect you to all of our video podcasts. And we have actually a podcast called Quest for the Good Life that I do that drops every 2 weeks and is on any platform that you want to use, which really brings in a lot of national discussions about best practice services and about technology and how we use it as a country. I probably don't need to tell anybody on this call that our workforce is disappearing, but we do want to point out that we've done research on this for literally 4 decades, and I can tell you, for 4 decades, the data you're seeing on this screen has pretty much been the same. We have, and this is data up to the pandemic, and what you're seeing here came from Ancor, if you're familiar with Ancor. But DSP turnovers always exceeded 50% as a nation, or very close to that, or higher. What is slightly has been increasing across time, though, is excuse me, is 69% of all the care is delivered by full-time staff, and 31% is delivered by part-time staff. You'll see that this is probably one of the most challenging statistics, because part-time staff, part-time positions are open twice as long and twice as often. They are directly related to a lot of the nation's instability in the workforce, because it puts so much pressure on full-time staff. They have to go through that. Normally, part-time people work more disproportionate on weekends, and they work at odd times, and that makes it very, very challenging for our workforce. One of the things that we do is that we work extremely hard nationally and have done incredible, really great work on scheduling strategies, which is important. In that we're averaging right now, both with the agencies we work with across the country and at Good Life, to have over 95% full-time staff. This reduces the number of people involved in care significantly, and we really champion 3-day work weeks, which has a 40% extra capacity to provide additional support compared to 5-day work weeks. So those are something that's unrelated to our presentation, but actually everything that we do at Good Life is focused on how we can improve the stability and quality of our direct support workforce, which includes the technology. The impact of COVID, however, has changed everything that hadn't changed in 40 years, that in ways that actually will never change again. I mean, it will never go back. And that is that when COVID happened, all industries, including the people I'm seeing on this screen, pivoted to working remotely. This is in every industry. And we quickly learned two things. One, many companies realized they could recruit better and farther. I mean, people that worked in San Francisco, 8 companies that worked in San Francisco realized they could hire people from Kansas a lot less costly, and did. And that's why, you're seeing lots of rural areas have more challenges. But the reality is, they also found out the employees very much liked it, and specifically the employees that were otherwise caregivers, because 81% of the employees who are caregivers nationally are women, about 35 years old, many of whom have children, and 65% of them are the primary breadwinner. It became very important for that group to start working remotely when they could, for life balance, and they learned that they had these opportunities. What that really means is, before COVID, agencies like ours and other agencies like ours would compete with each other for staff. That's no longer true. 65% of everybody looking for a job now is looking for a remote job or a remote hybrid job. Our greatest competitor is not each other, it is remote work. And it is happening in a way that we can't figure out how to compete against them until recently, and how we were essentially proposing some of the work today. Also, though, other things happened at the same time as COVID that sort of spurred forward our problem of a disappearing workforce. One really notable thing is that people are becoming seniors 65 years of age or older, 1 every 8 seconds, or 10,000 a day. And this tsunami of a senior population is hitting the care industry, and will be exponentially hitting the care industry in the next 4 to 10 years, to the degree that it is going to consume a lot of direct support workforce. And there is long known that 70% of all seniors are private pay, and they can pay better, and they do pay better than the IDD workforce. So we're going to have a serious problem with senior care. Add to that, we're shifting because not just the final rule, but just public opinion is shifting, and COVID did start this as well, push away from group care, such as assisted living or any kind of group care, for a variety of reasons, to in-home care. And of course, the final rule for many years has pushed that even further. And we're dealing with the fact that home sizes are getting smaller and smaller and smaller. And as home sizes get smaller, there's two important things you need to know. One is there's some barriers related to it that I'm going to go over in a minute. And schedules become more fractured and more wonky as home size gets smaller. For example, if you're working with in-home care, you're usually working on a 1-to-1 ratio. That means that we're going to consume more staff, and we do consume more staff as home sizes get smaller. The schedules become more fractured because people's needs, when you only serve one person, and if they're intermittent, and most are, could be at any time, or their schedule needs can be at odd times, and that doesn't make it easy to deliver care cost effectively. In addition to that, it has caused an increase in the percent of part-time people who are providing care because of the wonkiness of the schedules. We actually use technology and new staffing partners that have solved this problem. I'm not going to go deeply into that today, but one of the models that we have championed is called the Neighborhood Network. The Neighborhood Network won the Moving Mountains Award in 2020 from Anchor and the University of Minnesota Research and Training Center and the National Association of Direct Support Professionals. And prior to that, in 2016, it won the Most Innovative Program internationally by the Autism Speaks for an award for that. And the point is, it's a neighborhood staffing program that has enabled us to deliver care with full-time staff working 3-day work weeks leveraged by technology. And instead of providing support to an individual home, technology has allowed us to do it for a neighborhood. We'll get to that in a little bit, but that's kind of an advanced use of the technology that we're happy to share, and it's on our website if you want to learn more about it. But the point I want to make is that there's lots of barriers to how traditional care is done in-home, in small homes. I would tell you, if Uber delivered rides like we deliver care, there would be a driver hired for everybody that needed a ride, and that would be impossible to do. That's exactly how we deliver in-home care. We hire somebody for each specific home as if they're on an island, not connected to any other home or any other community that we support. And when that happens, you have lots of care gaps, because when people quit, then you have care gaps that we have to fill. In fact, I can tell you 2 states we work with right now, Alaska and Arkansas, are only delivering 49% of the authorized care to people in-home care simply because they can't find staff to regularly supply those hours. That's a serious problem in our work. And other kinds of problems with in-home care is that when you have all these small homes, which we all want, it's harder to train new staff. It's harder to support new staff. It's harder to supervise the care delivered. And you have a greater reliance on sort of just in case care, which means that you have to put people in the home waiting for a need to exist. And the cost for care, housing, transportation have all increased, and that's been very challenging for us to keep up with, and certainly try to pay people what they need to be paid. Now, I am not a fan of congregate care. In fact, Good Life has been associated with closing 6 institutions nationally, literally dozens of ICFMRs nationally, and creating alternative pathways for living in the community. So we're not a fan of congregate care, but every time I've worked with congregate care and families that have their loved ones served in a group environment, you always hear the reasons why. And there are reasons that exist, especially for people with complex needs. We study these barriers as behavioral analysts because if you don't understand the reasons why congregate care persists, in spite of our desire to not have it, or the barriers that prevent us from doing in-home care effectively, you can't design an effective care model that circumvents these barriers. But the barriers for congregate care is that it's easier to supervise because you have a core group of staff that's supporting a variety of people who have intermittent, unpredictable needs. And because of that, you also have the ability to work through care gaps because there's still people present and you're never without people. When a new staff starts, there's always experienced staff that work alongside them. So there's these ways to help and make, there's easier ways to provide supervision. There's easier ways to provide training and support. There's easier ways to provide a clinical service in congregate settings than there is in individual home settings, unless, of course, you use alternative ways like we're going to talk about today, technology. And because of all these issues nationally, we just can't keep up using traditional services. For example, this is again national data, 83% of providers are turning away new referrals, 63% of providers are discontinuing programs, 55% are considering additional service discontinues, and that's just last year. But the most compelling issue is that as a nation, over 50% of all the services that we provide are no longer provided by providers like us and like the people that we're helping today. They're not providing them. Over 50% of the services are self-directed or provided by families. In fact, providers are becoming less and less relevant, and people who are self-directing care are becoming far more the dog instead of the tail with respect to the service delivery. And this is leading across the country to multiple states. In fact, almost all of the states we're working with now are hiring families, even as employees, to provide services to their adult family member in their home, whether it's a shared living method or an actual employment method. Department of Labor has even provided an exemption to allow employees to be parents and family members to be hired as employees and deliver services in their own homes. There's tax advantages to it. You're seeing a whole creation of a new industry where people support themselves. This is all happening because providers have not been able to keep up traditional services. And there are some pluses about it and some negative things about that as well. The bottom line is that traditional services just aren't the answer anymore. Traditional care can't meet the needs that ebb and flow across intermittent times. I will tell you an example with my parents who are no longer with us. But my parents, between them in their last years of their life, could do about 90% of the things they needed to live independently. Between the two of them, they could help each other and do about 90% of the things that they needed. The problem was the 10% were intermittent and unpredictable problems that they couldn't solve. So they had to trade 90% independence for 100% care. As a country, we can't keep trading 90% independence for 100% care. We do not have the financial resources to do that. We don't have the human resources to do that. We need to create new models of care that can fill those gaps, that can fill the gap between what natural supports can do and what people need to live a good life. We need to have a way to meet intermittent needs that can ebb and flow. And we need to have a way to have both in-home and remote supports work in concert so that we can fill this gap organically. And we're going to get into that. So obviously, I'm leading ahead with the solution for the next generation of care is going to be technologies combined with human support. But I do want to tell you that we sometimes don't look at other industries and how they solve problems before we head out and try to solve it ourselves. We try to do this in all the work that we do at Good Life in the University of Kansas. It's important to take lessons from other industries and how they solve similar problems. Let me give you an example of the story of Blockbuster and Netflix. Blockbuster, as you know, was a store where people went to rent movies. It was designed for the convenience of the store owner, where the people had to, migrate to the store and pick out their movie and take it home and bring it back. That's the service that they did. And then along came Netflix. who had a different business model. They used a technology platform to connect to their customer base and deliver movies to them without the store. Now, it started off as just a mailing service. It ended up being the world's largest streaming service that provided movies anytime, anywhere, on any device at on demand. It changed entirely how services for movies were done. It did not bolt on technology to a blockbuster business model. It changed the way they delivered services under a new business plan to bypass the store. I give this example because that's what Amazon did and are doing. That's what Instacart has done and are doing. That is what Talkspace has done and are doing. They all have bypassed the store. They bypassed the clinic. Station MD has bypassed the clinic. Remote Health has bypassed the clinic. They're going directly to the person and using a platform of technology to do that. So we believe that the solution for the next generation of care is new human service models that are enhanced, delivered, leveraged, and supported by advanced technologies. This will leverage our costs. It will help us. We should design it to overcome the specific barriers for in-home care and gain the advantages that congregate care has that have not been available to in-home care, so that we can deal with people who have complex needs, and we can improve at the same time the support for our nation's disappearing workforce that we haven't been able to do using traditional services. So I want to take a minute because it's important for you before I show you the technology or that Megan and Beth do. But the problem with most independent living technologies is that they're not integrated into human service models or delivered by people who know the person well. That's really the problem with the current state of them. They're not designed to take the full advantage of what technologies have to offer. Sometimes they're just bolted on top of existing service models, which do help, but they don't make available what's made possible by technologies. We've designed new service models and we help people implement new service models that actually were designed from the ground up to be leveraged and used by technologies. But the other thing I want to point out really specifically is technologies in IDD are often consumer-based and not agency platforms that provide support. Now, I am certainly not against consumer-based technologies, but if you take your iPhone out and you open it up, you will see, hundreds of files, probably at least dozens of files that you have or apps that you have that you use. And that's sort of the state of many of the support, the technology supports for people with ID. There's an app for that sort of support. There's an app for this. There's an app for that. Everybody has a unique app. The problem is if you serve 200 people and they each had 10 apps, you're having hundreds and thousands of unique programs that are consumer-based that the agency cannot support or maintain from its viewpoint. And it is not how people have done services in other industries. Uber wouldn't allow everybody to have their own unique app that isn't Uber to get a ride. If people who have EMARs in IDD services don't let each client pick their own EMAR. We don't let each employee pick their own video conferencing service. You guys are a Microsoft shop and we're a Google shop. Our employees must use Google or Microsoft, or we use the same CRM for supporting customers, or you have the same information management system for supporting clients. That platform still allows individual information. It still allows individualized services. Uber, for example, is a platform to provide individual rides for people exactly the way they want it. Just because you have a platform does not mean the services are not individualized at the client level. The problem is if you don't have a platform of support, an agency has no way to implement it with scale and integrity and safety from a HIPAA perspective across people. When you allow that much eclectivity in consumer-based technologies, it makes it very challenging. Does this mean that we don't want them? Of course not. It just means that an effective remote support program for an agency is a platform of support. And it needs to be that so that it's scalable and useful for people. And that's all control at the cloud level. So the question should we allow virtual support instead of human support? First of all, virtual support is human support. But if the question is, should we allow remote support instead of in-home support? That isn't the question that any of us would accept. For example, when you guys are participating today, you're not all present. Some of you made the decision to remotely check in on this meeting. Others have attended it. You make decisions every day on things that you do that would be remote versus in person based upon unique circumstances that can change on a dime. And it changes every day. Sometimes you meet with people personally. Sometimes you do it remotely. You might do it because it's a new person and you want to develop a relationship. You want to meet them in person. Sometimes it's too far, or sometimes you just have a bad hair day and you decide not to do that. So those are the kinds of things we do every day. And every time a opportunity presents itself, we make a decision ourselves whether we want to be remote or in person. And I can tell you that's what most people want to do in life. When you look at the people that we serve, they want to know, they want to have a complete choice on when they receive in-home versus remote supports. And that is not something that they put in a person-centered support plan to say, I want this or that. It's some decision that they make every moment of every day based upon every need. And that's the way it should be done, in our opinion. Needs organically should ebb and flow between remote and in-home supports, both for staff and for persons that we support. But the most important thing is whether it's in-home or whether it's in person, we need to have the same capabilities to deliver support. And we'll talk about that in a little bit. And we need to be able to have it delivered by sometimes the same people or people that know them very well, because it's not a call center approach. It's a personal approach. So we have taken it upon ourselves to create new care models that overcome barriers for in-home care, better support DSPs, help deliver health, behavioral training, supervision on demand, exactly when and where it's needed, provide remote and in-home scheduled and deployed supports that can organically ebb and flow around need to fill the gaps in care so that people don't have to provide just-in-case care. Help families and providers fill gaps in care instead of trading independence for dependence in congregate arrangements or when they have complex needs. Less intrusively detect needs and identify when care is needed. That's a really important component of direct supports. Empower DSPs with full-time work, and we can do that. And direct supports make that possible. We can share that later. But most importantly, we believe that technology should, as its goal, advance self-direction, independence, privacy, and remove complications for receiving professional support over what's currently possible with traditional in-home and group care. So I'm going to introduce what iLink Technologies is, and then I'm going to have my team who's on site show a little demonstration. We'll talk about it again. But iLink is a framework, or it's an infrastructure. So we don't do remote support for an agency. We use a teach-it-to-fish model where we provide the infrastructure to an agency, and then they in turn will help provide remote supports to person they serve in DSPs, and they can also help other agencies as well, you know, by showing the technology to them so that we have use cases of it, so they understand how remote supports can be used effectively with new service approaches. iLink allows the right support to be delivered at the moment and place of need by support staff who know their clients best, utilizing advanced home automations, smart sensors, controlled by cloud-based software, iLink provides sustainable support without unnecessary intrusions beyond what's ever possible with in-home staffing alone. iLink can transform an agency with stabilized staff, reduced turnover, higher quality of care, and a high level of independence and self-direction and choice. And those are the outcomes that we try to achieve. So we're going to talk and show you a little bit of the demonstration. I'm going to let my team do that there. But let me kind of preface by saying there's two parts of it. So we're going to show you the hardware and talk about the software. But really, our platform includes both iLink Home, which is a hardware and sensor-based solutions, and that is controlled by the software called iLink Assist. And iLink Assist is a cloud-based software that's ever evolving. You sign into that like you do a Teams, or like you would do Zoom, or like you sign into your any other cloud-based app like your Microsoft or Google, a Gmail, or anything like that. You sign into the iLink Assist, and within that platform, you can basically customize the experience so every home can have a unique experience and support based upon the rules that you want to assign for that. And we'll get into that in a little bit. But I do want to say this. You're going to see different versions of it. There's different, you're seeing on the screen, one version, there's another one that's going to be demonstrated. But the bottom line is when you do virtual or remote support, if staff are supporting remotely or they're supporting in the home, they have to have the same capabilities to do that. If you're in the home, you need to be able to see, and you need to be able to hear, you need to be able to sense, and you need to be able to act, you need to be able to talk and communicate. When you're working remotely, you need all those same capabilities to do an effective remote support job. If I'm doing a demonstration, I want to have a meeting with somebody where I want to see if they can demonstrate a skill, even on this call, I would need to see you. When I do presentations across the country, I personally like to see people so that we can interact with people and I can make sure that what I'm talking about is getting across. Sensors, all these kinds of things are things that are necessary in order to effectively deliver remote care. And remote care, it can be demonstratively shown to be more private and less intrusive than in-home care on every dimension. And we're happy to show that information to you. But the reality, and it's true from the consumer perspective, they prefer it as being less intrusive. The federal law suggests that you are supposed to use the least intrusive, potentially effective approach for care that can accomplish the goal that you have. And there are several expectancies of care at the federal level. Privacy is one of them, but independence, choice, self-direction, safety, and there are many other expectations of care that have equal standing. Our goal is to pick the approach to care that can achieve the expectations of care in the least intrusive way possible. And that means that in-home care is no longer given a free pass on intrusion. Your job is to compare the different approaches to care and use the one that can accomplish it in the least intrusive way for our customers, or at least from their perspective. So with that being said, I'm going to turn this over and show you a little bit how our technology works. One particular feature that Beth is going to show you is very important to us, and that's about self-direction. I'm going to tell you that the most important skill that you can teach anyone to be able to live more independently, safer, with greater choice and control is the ability to know when and how to ask for help. Technology makes this very simple because it requires, in our world, one finger and one button as the only thing that's necessary to get help. And we measure that as an agency because we always want to know how many times people ask for help, because we believe that that's a really, really important metric to show that people are taking control over their program. Beth, you want to show it?
Absolutely. Hi. I'm going to show you just one of the examples of the remote technology that we offer. One of them is also on the screen right now. That's called our Ruth device. that you're seeing on the screen, you can see that the blue lit button on there is the one button Mike is referring to. And then you have an intercom, which is the same intercom I have right here. And then that device has a camera on it as well. So the one I'm going to show you is a little bit more of a self-directed device, a little bit more typical looking. So this device right here can just go on a shelf. And it has what we call an eyelid on it to provide some additional privacy. If somebody is able to self-direct and cover their camera, then they can just do that very easily like this. This sits on a shelf and can provide that scene part that Mike referenced to you. The person may decide that the only time that they want to remove that cover is if they need help with something. Maybe they need help cooking their favorite meal and they can remove this eyelid so that they can get some assistance with the remote support center in teaching that skill. But if anybody wants to call at any time, they can use this intercom we have right here. They just press this button and it calls the remote support center. I'm calling the remote support center that we have in Kansas.
Link is connecting your call.
See that there's a nice sound on this intercom. Good morning. This is Beth. We're just doing a test here in Connecticut. Thank you.
Thank you. You guys have a good day.
You too. And then, of course, they can call back and the person on the end can just answer very easily. They just have to speak. And then that's your two-way communication, nice and easy. Every single call that's made on this is processed, what we call processed in our software that Mike referred to, so that there's a rationale for why that call happened. That way we can keep record of what are the typical things that somebody's calling to get help with. So maybe we can get ahead of that in the future. All of our technology also comes with this just small box right here that plugs into your internet. It's a nice and simple installation. We do all the configurations in Kansas City and ship them ready to go based on what is needed for a particular location. So it's a mesh network. There's no need to do anything behind the walls. And then all the sensors are also paired. We utilize a lot of sensors to help us understand when people are coming and going from locations. For example, if you're only concerned about somebody who's leaving in the middle of the night, then a door sensor can provide you that information, because in the software, we will be able to say, we're only concerned if Mike is leaving between 10 p.m. and 7 a.m. And that's the only time our software will provide that alert. And then the remote support coach can look at that, figure out what's going on, and call for help if necessary, or just walk through that with the person remotely. Oh, and one more thing, this is a little light that we have that you can plug into any place in the home. It lights up, and Mike has a slide that'll show it to you. It lights up red if the cameras are off, so the person can see for sure that their cameras are off if they choose not to use the eyelid. And then it's green if it's on, and it's blue if it's in privacy mode. And the privacy mode is a blurred image that you can tell, and that's that middle one there. You can actually see if somebody's walking through the frame, so you can tell if somebody's in the room, but you clearly cannot tell who it is. So those are the different options, some of the different options that we have for the technology.
So if I could go ahead and say that, Beth, but the important thing is that little night light that you can plug into any outlet in a home basically shows red, blue, or green to indicate whether the camera's on, it's off, or it's in privacy mode. And the customer can choose which one that they want to be in. They can also do what I call the old school approach by putting the eyelid on if they feel more safe with that. From a privacy perspective. But our goal is to make sure people always know, what kind of support is being provided, and that they have choice and control over all of that, which is really important, because that's what you have when you are either participating with where I can see you, or you can change your background, or you can show yourself. That's your choice, and you have the control over that. We try to offer that as well. But we also want to do it in a way that's simple. So it can be as simple as somebody pressing the button to say, hey, can I have some privacy? They give them privacy and the light changes, and so they know that they have it. So, or they can put the eyelid on if they prefer to do that as well. Privacy is super important, but so is the ability to see and sense. I want to talk about that for a minute. When you don't have advanced software like iLink Assist, normally what the people try to do is they try to architect what's in the home by putting in sensors or not putting in sensors and trying to control things that way. That's sort of an archaic way of creating control. I give an example of your iPhone. You have literally scores of apps, but you have in every iPhone, there are 7 sensors. And you don't get to choose what those sensors are. They are in all of your iPhones. You can get a smart ring, it'll be the same way. You can get an Amazon Alexa. It will have a set number of sensors in the camera. All those are included. It's the software that govern what you see, what you don't see, what sensors are active, what sensors aren't active. And why that's important is because our needs change organically over time. You may need supports that are provided by those sensors at some time. Therefore, they're there. That doesn't mean that they're enabled or that you have to use them, but it does mean they're there. As an example, and to talk about how the software is advanced, in our software, combining it with sensors, if you get up at night and you walk to the bathroom and then you walk back to your bed within 5 minutes or 7 minutes, for most of us, that's not a problem, is it? That wouldn't be considered a need for help. But what if you walked to the bathroom and you didn't come out for 15 minutes, 30 minutes, an hour, 2 hours? I guarantee you I'm going to say a time and everybody's going to raise their hand and say, oh, we should check on them. That kind of individual configuration is always possible because of the logic we have. And it would let us know that somebody went into the bathroom and didn't come out in the time. So we should at least get an alert and check on them to make sure that they're okay. Or somebody left the premises after 10 o'clock. Maybe that's okay for some, but it's not okay for other people. So those are the kinds of things we do. Or that somebody's in the kitchen, they turn the stove on, and then they left the home when they left the stove on. It's probably, as apartment owners and developers will tell you, that is the most dangerous thing that happens in their development, is people leaving the stove on and leaving and walking out of the home in a multi-use facility like that. So the software basically filters out times where you don't need to help somebody and filters in times that you might need to help somebody. Why is that important? Is because that advances privacy. You are filtering out times where help doesn't need to be there, or you don't need to check on people, and you're filtering in times where they need help, which means that your privacy is being advanced. If you're providing in-home staff only, they are surveilling need. They are there whether they're needed or not, and you can't turn them on, turn them off, or use them anytime that you want. That is more intrusive than being able to control all of those functions and more private. So those are the kinds of things that are important to know. Also, our data is cloud-based, it's HIPAA compliant, it's encrypted transmissions, and it has multiple redundancies. And an agency doesn't have to maintain that software. Any new release that we do organically provides itself just to the cloud as those releases are made. And what that also means is that we are constantly developing new technologies. And you know, what Beth showed you is really important. It's just the hardware side of this, but we're working on software and hardware advances all the time. Right now, for example, this year we're working on beacon technology, wearable beacon technology, wearable biometric technology, so that we can get data for people who may be not who may be having stress in their lives. For example, the number one time of death for people with IDD is at nighttime, especially if they have seizure disorders or heart conditions. It's when they are not highly monitored. Biometric data will very soon give us alerts that somebody's in stress. It may be that their heart rhythm is off. It may be that their O2 is too low. Alerts can be created under certain conditions to give that data so that we can check on people at times when they're most vulnerable. And the alternative for that would be to be a serious breach of their independence. So privacy is protected. We want to balance privacy, intrusion, and safety with care. And cameras act as highly sophisticated sensors. Let me give an example of that. You guys all have cameras around your car. Most of the time, sometimes you can see, sometimes it just vibrates when there's a blind spot, but it's still a camera. A camera by itself doesn't share an image unless the software allows it to do that. But a camera can be used, for example, to do facial recognition without sharing an image. It can be used to communicate that somebody is in a wrong area of the home without sharing the image. It can be digitized with a camera. You can fuzz out all of the images like Beth showed you, or you can black out certain areas of the home that you don't want to see, even if it is turned on. This allows us to have customized privacy in ways that's not possible by in-home staff. So I'm going to kind of end by talking about that there's so many functions that you can do just at the beginning level with this. Our technology, by the way, is designed to work with people who self-direct care or agency provided care. It will work for people who just need help to live independently, but it can also work to support staff who support people with complex needs who are working alone and need help when they need it. It can be used for night support, remote health, remote behavioral support, service coordination, supervision, training, and support. We specifically use our technology to support new staff who are working alone, because the first 60 days of their work is the time where the highest turnover exists, primarily because they don't know how to do their job and they don't have immediate help. And of course, remote quality assurance. So, you see examples of how it can be used with vacancy management, supporting in-home directors, and on-demand behavioral support. The traditional way of doing behavioral support is you gather data and you come to a meeting and you talk about it. But that's very different than being able to help somebody immediately on demand, providing coaching to people when there actually is an emergency or a need, or providing follow-up for nurses with health to provide health needs. At Good Life, we have about 400 people. They're supported by 3 nurses working as a team remotely, where they can observe people who are new giving medications. They can go and help people follow up complex medical needs, or if somebody is having a health concern, they can have a personal consultation on demand for those kinds of things. I'm going to stop there and just sort of, we just got a few minutes left. If there's any questions from the group, if they could, either come on and ask the questions or text them, however they want to do it, and we can answer any questions you might have. Anybody? While you're doing that, I am just going to tell you that we're exceedingly excited about our partnership, and we're really excited to sort of empower an agency to help other people and other agencies in your state sort of come to another level of option for people who are needing help to live with greater independence. And I'm hoping that this also ushers in new models of care that could, absolutely address issues of not only the workforce, but the ability for people, especially those with complex needs, to live better lives in smaller homes in your community. Anything?
Thank you, Dr. Mike. So I just want to add to that, you heard from Mike Gibney at Hark a little at the very beginning, talking a little bit about how we are using this partnership. We are very pleased to be doing this in collaboration with DDS as one of the awardees under the Notice of Opportunity that was put out back in March. So we're super excited to build this, and we hope that you as case managers will spread the word about our services, and that you will consider this as an option for the individuals that you support, so that we can really kind of help to promote independence across the state.
And we're happy to share our work in other virtual ones, or if you have conferences in your state, to actually come and speak, and then maybe exhibit or do partnership presentations with Hark on that. This is an incredibly important project, and we're real grateful for all your support. Well, thank you.
Thank you so much. Are there any questions out there? All right, with that, I think we will, we have a question. Go ahead, Tammy, if you want to unmute.
Absolutely. Not necessarily a question, just a comment. It's been, great to hear. Excited for Hark to see the opportunities that we can, serve people through different service models. It's exciting. And I really enjoyed the part of the presentation. I think we all know in this industry how we've struggled with keeping staff and filling positions and filling vacancies. I loved the layout of how you guys were able to really bring to light for me the issue on a national level, but there are some good opportunities for us to start to address those issues. So I found it very helpful, and certainly wish Hark the best of luck moving forward with all this. It's exciting.
Thank you so much. We're super excited.
Very good.
All
Well,
right.
Thank you for coming, and we appreciate everybody's time.
Thank you all. Okay, thanks
Thank you so much.
all.
Thank you.